So hello, and thank you everyone for joining us on today's webinar. Today's topic is denials management, where we will talk about strategies to reduce revenue loss and rework costs. This event today is being recorded as well as qualifying for ACHE credit. The credit survey and the link to where the recording will be posted will be sent in an email following the webinar today. My name is Caleb Lozinski, a program coordinator with the National Rural Health Resource Center, who is providing this webinar. Please connect your video feature by selecting the camera icon in the lower left corner of your screen. Your audio is muted by default to avoid background noise and feedback. Please remain muted unless you have a question. To unmute your line, please select the microphone icon in the lower left corner of your screen. If you dialed in, press *6 to unmute your line. You can also communicate through the chat box, which is located in the bottom ribbon in the middle of your screen. If you haven't already, please take a moment to type your name, title, and organization in the chat box so we know who is joining us today. The National Rural Health Resource Center is a nonprofit organization dedicated to sustaining and improving healthcare in rural communities. The center is the TA provider for the Delta Region Community Health Systems Development Program. The Delta program is funded by the Federal Office of Rural Health Policy in collaboration with the Delta Regional Authority. The center is committed to diversity, equity, inclusion, and anti-racism, and building a culture where difference is valued. You can learn more about our commitment on our website. Now, before I do a little introduction on our wonderful speakers that we have today, I'm going to go ahead and get the pre-polling questions launched. I will launch post-polling at the end of the webinar today, and it helps us measure knowledge gain. All right. So as you can see, we have two wonderful speakers today from Forvis. Jonathan is a member of the Healthcare Performance Improvement Team at Forvis, where he focuses on assisting healthcare organizations with revenue cycle and financial performance improvement. He has experience serving healthcare systems, hospitals, physician practices, and other specialty healthcare providers. Ryan is a member of the Healthcare Performance Improvement Team at Forvis. He focuses on revenue cycle transformation, integrity improvement and compliance, as well as helping providers as they undergo ownership or technology changes. He has extensive experience serving health systems, physician practices, and other healthcare providers. I will turn it over to them to get things kicked off. I appreciate it, you two.
Thank you. I appreciate it, Caleb. We are excited to dive in here and talk through a topic that I know all of you live day to day, and that's insurance denials, how to strategically manage and more importantly, reduce revenue loss and rework costs. So I think Caleb did a very nice intro. I don't think too much else to discuss other than just a quick, I am Ryan Roswada, Director, part of our Forvis Healthcare Performance Improvement Team. So we're a team within Forvis that has various clinical, operational, financial experts. My background is in revenue cycle, led a denial management team at a larger hospital organization, and have been doing revenue cycle work for about the last 10 years. And Jonathan, you want to do a quick intro?
Yeah, hello. My name is Jonathan DiValerio. I'm a senior consultant on our healthcare performance improvement team here at Forvis. So similar to Ryan, my background is in the revenue cycle, so the back end of the rev cycle. And I also have some experience doing value-based care work. And so we can go ahead.
Yeah, I'll start with a quick agenda. So as far as the next 50 minutes or so, we plan to cover insurance denials, impact, and recent trends. So like I mentioned, we do a lot of work with clients in this space. So kind of laying out what we're seeing, hearing within the industry. And then we plan to move to denials prevention and management and really break it out into two components. Talk through denials and appeal management best practices, knowing at the end of the day, you all are going to have accounts receivable. So what's the easiest, most efficient way to tackle that? Then we'll move to prevention strategies, so tactics to avoid revenue loss, rework costs. And then finally, we have a couple case studies, examples of initiatives that we've worked on that you may be able to bring back to your organizations. As we're going through here, I actually just did a webinar yesterday on this topic. Maybe a few people that were there yesterday, but if you have any questions, feel free to message those. We'll try to save some time at the end. If not, we can take a snapshot. If you provide your email, we'll get back to you by email. That being said, I will dive in here and we'll talk through insurance denials, impact on healthcare organizations. And I think a great way to look at it is just really at a high level as far as kind of what buckets are being impacted. We kind of think of it in 3 different pillars or core areas. And the first one's financial impact. So likely the most obvious one, but a couple eye-popping statistics here as far as just the sheer amount of revenue loss. So this was a Change Healthcare study that found hospitals lose about 3% of their net revenue due to preventable claim denials. And Jonathan and I work a lot in this space. I can attest to that. We see, say, anywhere from 2% to 6-7% on average when we do our assessments. So big dollar amount just from revenue loss. The other thing to keep in mind is the cost of rework. So another study that found about 12% of hospital claim charges that are submitted receive at least some sort of denial. So a little more of a hidden cost when you think of the average cost to formally appeal a denied claim, especially if it involves a physician advisor or someone with more of an expertise. A lot of times we see organizations that get stuck where you have too much of an inflow of denials, not enough staffing. So you have to leverage a vendor that can charge 10 to 25% in some cases. And then obviously the reduced speed to payment and ability to receive timely payment be the third element. So those are 2. And then I would say the third pillar that we have is patient experience. So unexpected patient liabilities. We've seen, especially more recently, where the patient has to be involved or in order to be successful involved in a complex appeal process or just delay in patient care. If you think of authorization denials up front, services often need to be delayed or canceled due to a missing authorization. So that's a little bit on the background. I did want to talk a little bit through the insurance denial rate and kind of the increase over the last 5 or so years. So another study that was done recently that found there's been a 33% increase in the national average denial rate. If you think of 2016 to 2022. Another one that we can attest to that we've seen across the board. So about 4 or 5 years ago, when we did our assessments, we'd see about 10%, 5 to 10% was more the industry average. If it was above 10%, that would be a cause for concern. Now it's closer to, I'd say 15 or 20% that we see a lot of organizations at. So actually even more dramatic than what this national study has shown. So a lot more rework costs involved, a lot more denials across the board, regardless of how well your organization's performing, a lot more complexity too. There's been 100,000 estimated payer policy changes between 2020 and 2022. So that's a little bit of a background. I did want to talk through health systems issues with Medicare Advantage plans and denials. This is one, something that we've seen more recently, and I think it ties into denials, but we've seen where Medicare Advantage plans denying payment more than they have historically, and organizations are at the point where they are pushing back. There's been 13 recent instances where health systems have dropped Medicare Advantage plans altogether. So the other thing I would bring up related to that, there's been several recent class action lawsuits, 2 against UHC and Cigna for the use of artificial intelligence. So using technology to process claims and maybe debatable, but inappropriately denying claims or denying claims without the level of expertise that's needed. So something that we're seeing and hearing about. Another trend, not necessarily a trend, but just kind of painting a picture of the increased complexity of denials. So health systems are really struggling with the volume and complexity of denials and information requests. I'm not sure if everyone here is involved in the full process of revenue cycle, but we thought this would be a good starting point as far as kind of showing, if you really think of denials as any request for information or I guess that would be the best way to put it. Any request for information, there's really 3 buckets that it falls into. It's not just your traditional, hey, if I'm not in the revenue cycle, I think I send out a claim, I get a denial. So you have your pre-service or concurrent denials, peer-to-peer reviews, your pre-service outpatient denials. So that would be like if you submitted an authorization request. And then on the post-service side, you have DRG downgrades, paper correspondence. You have technical, clinical denials, coding denials. So a lot more of what you consider the traditional claim denial. And then I would also consider post-payment denials and commercial audits, payer takebacks, government audits. Those also require a strategy to really tackle effectively. So just some information on the landscape there. And I think that ties nicely into our final slide here as far as, the top challenges that we're seeing for rural healthcare, really rural healthcare, but providers at large when it comes to tackling and addressing the issues that I mentioned. One's revenue cycle staffing. So you all live in this world, but a lot of times what we see happen is staffing is really meant for more of the day-to-day, and there's a focus on just following up on claims, appealing claims, where we see a lot of the big opportunity is more in that avoidance space, and having the staffing to proactively approach with prevention initiatives and staff education is something that's just very difficult when you're trying to just staff for your day-to-day operations. The second one is denial visibility and reporting. So this may depend on the EMR, the reporting systems that you have in place, but I would say across the board, we just really haven't seen great systems in place without purchasing an outside software that provides you the ability to monitor your denial trends proactively, kind of see what are the specific CPT codes that are getting denied, what are the providers, some of those granular level trends, being able to actually look at the claim level detail of denials. Just something that most of the systems right now are more at an ad hoc basis. And then the third one is technology adoption. So I mentioned Cigna and United Healthcare using artificial intelligence to process claims. Many of the healthcare organizations we see are significantly behind payer adoption of advanced technology. So payers may be spending 25% of their budget on these technologies and automation and processing claims. On the provider side or on the hospital, other healthcare organizations, it may be 3 or 4%. So not that there's not anything you can do about it, but it is somewhat overwhelming to have to be going up against some of these larger payers. So that is a little bit on the top challenges. I was going to hand it over to Jonathan to talk through the Medicare Advantage rule and its impact.
Yeah, thanks, Ryan. So kind of like Ryan had touched on earlier, really with that increase in Medicare Advantage related denials that we've seen over the course of the last few years, there has been some pushback, like those lawsuits that we had mentioned, and also from CMS. So back in April of 2023, CMS approved a new rule really aimed at providing relief to Medicare Advantage related denials. And so that rule went into effect at the start of this calendar year, so January of 2024, and does a few things really aimed at addressing some of those challenges. So it really does look to align traditional Medicare and these MA plans more closely, specifically on those coverage guidelines. So in the past, MA plans could add a different criteria on top of what Medicare has already laid out as coverage guidelines. And so what this rule really does, it basically says where there are clear-cut traditional Medicare coverage guidelines, MA plans can no longer add that additional criteria. And in some cases where Medicare, there aren't, clear-cut coverage guidelines, MA is still allowed to add their own criteria in those circumstances. But this really does more closely align those traditional Medicare coverage guidelines and those MA plan coverage guidelines. So on the other piece, they're really trying to tackle and address some of that authorization burden that really falls on the hospitals. So requiring from the payer side, those that are reviewing those auths, they have to have some type of relevant clinical expertise. So I know, like Ryan had mentioned, with AI kind of going through all of those auths and denying them, CMS is now requiring that to review those auths, you need that kind of relevant clinical expertise. And they've expanded the approval timeline for those auths. And really that last piece is when patients are switching in between MA plans. In the past, that auth would expire and they would be required to get that new auth, which really affects kind of that continuity of care. But now this rule states that that auth is covered kind of during that transition between one plan and the next. And so again, this rule went into effect at the start of 2024. And so Forbes has a denials reporting tool that we provide to some of our clients. And so I was able to go in there and really look at, okay, are we seeing any difference at the start of this calendar year in terms of MA denials? And in general, what we've seen is a modest decline in both MA denial dollars and denial volume. And so again, small sample size, this is just at the start of the year, but definitely something to consider for those on the call is, has this rule had any impact on your organization, or has it provided the relief that we were hoping that it would provide? And so oftentimes, the focus on denials is with that denial and AR management, and that makes sense, working the denials that come in, getting those appeals out the door. Oftentimes that can feel like, keeping your head above water with really the influx of those denials that are coming in. But we really do want to highlight some of those high opportunity areas, that being denial prevention. So really identifying the root causes of denials and then addressing those at the root cause. And then on the analytics side, analytics really being that engine that drives denials prevention, allowing us to really identify what those root causes are, as well as kind of see those trends over time in terms of if that denial prevention efforts, is it being successful or not? So I know next we'll kind of talk through some denials management best practice here. So in terms of denials management best practice and strategy, it really is important to tackle it kind of in these three buckets that we have laid out here. So, being your people, your process, your workflows, and then, really on that technology side. So starting with that people, a really good place to start would be, looking at your staff and saying, okay, do we have enough people? And are they kind of aligned correctly? So really doing that kind of on a demand-based side. So looking at how many claims is our system sending out the door? How many patients are we seeing? What's our denial rate? How many, accounts do we actually have to work and send those appeal letters out for? And then assessing, do we have enough people? Do we need more? Do we need less? Do we need to really align our staff to where the demand is? And with some of these payers, there is some additional work. It might be harder to work a Blue Cross denial than it is to work a Medicare denial. So really aligning your staff to where that demand is. And then really on that staffing expertise side, so making sure the staff know how to connect with the coders or those physician advisors, and the staff throughout the hospital that really can support some of those more complex clinical denials. So does your follow-up staff or your appeal staff know who to connect with on the coding side, or know who to connect with on the physician advisor side? So really kind of taking that into account as well. So that really covers the people side of things. And now I'll send it over to Ryan to talk through the workflow and the technology side.
Yeah, thanks, Jonathan. was really well done. And as far as just this in general, we're trying to, should serve as a checklist, kind of things that we've seen really be successful in helping to improve performance. So on the workflow side, a couple key things that I would like to point out. So having a standard approach to route, monitor, and track denials. We come across a lot of organizations that primarily route or may route through email or just like inconsistent way. So ideally in the system, but figuring out a way, if we have an appeal that needs to go from the business office to a physician advisor, from the business office to someone in coding, that is standardized. So there's that component. Having a framework to prioritize daily staff efforts, and some systems automate this a little more than others. We have an example a little bit further, but having, without micromanaging, having structure and what accounts do I look at day to day, prioritizing those accounts that may be reaching timely filing limit, high risk accounts or high value accounts, making sure accounts that are new are worked appropriately and timely. So those are a few on the workflow side, a standard write-off escalation, and we'll talk through the appeal templates approach in a little bit here. On the technology side, what we see is really needed to drive performance, having ideally electronic and customized work lists. So Jonathan mentioned the demand-based staffing analysis and seeing, hey, how many people do we need on Blue Cross? This would be the next step in the process where you're customizing those work lists so they show up in a seamless fashion. There's not a lot of rework or trying to find accounts. Touch on one other one here, and that would be small balance write-off automation. We've seen where, and there's the component of automation where if it's under $5 or $25 and it's not worth the appeal effort, that's automatically written off. But then there's also been some vendors or some processes that can be automated as far as filing that appeal. So that would be another one I'd like to mention. And I think that'll take us pretty well to our next slide where Jonathan will talk through, I mentioned those insurance denial best practices and appeal templates. So he's going to talk through some of those items.
Yep. So in terms of that appeal process, really the key is two things, and that's convenience. So making it as convenient as possible for your appeal staff to get those appeal letters out the door, and then standardization. So really kind of keeping everything in line, and that really starts with both that appeal template and that appeal letter. So it is important to really establish that kind of standard appeal letter template for each of your payers. So when you need to file an appeal or send out an appeal for a denial, you already have that template kind of pre-built with some of those payer information, kind of pre-populated in there in terms of the address and just kind of those little things that make it much more convenient for your appeals team to kind of work through that appeal. And then really kind of the next step is that, the actual appeal letter, and really making sure that when it's written out and built out, you're able to really cite some of those regulations or those contractual pieces that really support your appeal. And being able to cite those things is really, really important. And we've seen a lot of success in organizations that are able to kind of cite the specific wording of the contractual agreement or the regulations. The payers will want to fight you every tooth and nail. And so it's, important to kind of have some of those objective agreement, statements in there. And then really the last piece, it goes back to that expertise. So having that appeal team, making sure they know how to route some of those complex clinical denials, being able to connect with that physician advisor. And if you don't have some of those resources in-house, making sure you have a way to, either outsource that to someone who will do those appeals, or being able to connect, outside of your organization to people with kind of that specific expertise that can deal with some of those complex clinical denials.
Yeah, thank you, Jonathan. And we'll definitely echo or stress the using state, national regulations, payer contractual agreements, especially when you're talking through higher dollar complex appeals where a lot of money is on the table. Sometimes there may not be a great clinical ground to stand on for appealing or defending a claim, but maybe the payer did something. I know we've seen state regulations that say they're supposed to notify you of an inpatient denial for admission or authorization within 48 hours. I think that was, don't quote me on this, I think it was Ohio that we saw that, but using guidelines like that as a creative way to be successful with appeals. Yep, Jonathan, I think this one's you as well here.
Yep. So AR management and denials do really go hand in hand. And it really is important to have some sense of structure really when it comes to reporting and your workflows. So having really that consistency in the team's work really will help kind of break down and really help you kind of identify some of those root causes. And so really wherever that structure can come from, whether it is that kind of denials or AR management framework, kind of like we have, demonstrated here at the top, where maybe in this example, the team kind of prioritizes a different bucket of work for each day of the week, really to make sure that they're tackling all of those kind of priority areas, or an audit scorecard. So you're able to really identify and have some structure around identifying some of those root causes, look through, your previous denials to really identify, what happened in this case and was this preventable or not? And then kind of lastly on that productivity checker that we have in the right corner. So some sense of structure when it comes to the workflows is really important to keep in mind.
Yep. Thank you, Jonathan.
And lastly, on the appeal side, really what we want to emphasize here is really that analytics. So having that visibility and that insight to that appeals process to really, both feed that information back to the internal teams. How successful are we at appealing, this denial, our auths or our med necessities, and what service lines are we seeing success in or not, or failures in. But as important, feeding that information back to the team is feeding that information back to the payer. If you have, say, an appeal success rate of 95%, you might be able to use that information to get the payer to the table. I know it can be very difficult to bring those payers to the table, but really having that reporting and visibility into appeals and appeal success is really something that you can use to kind of bring that payer in and kind of walk through some of those denial items. And so that really covers denial management in terms of best practice and appeals best practice. And now we'll send it back over to Ryan to kind of talk through denial prevention.
Yep. I appreciate it, Jonathan. I know appeal management is very important. I see a lot of people in the meeting chat that are in HIM, case management, some of those little more clinical areas. So being able to track your appeal rate by DRG, for example, or some of those trends where it's actionable. We have a dashboard example here, but really just a starting point for you all. So yeah, like Jonathan mentioned, I'm going to switch gears here and talk through denials prevention best practices. And we feel like there's a ton of opportunity at organizations if you think through all that rework cost of appeal. So what can you do to more efficiently avoid really any of that back end work from happening? And to us, it really falls into three different areas again, on the structure and people side, and it may depend on the size of your organization. So I'm going to list off some things. At larger organizations, it's an entire department, a revenue integrity department. Smaller, it may just be a responsibility of someone's existing, or it could be one or two staff that do a lot of these functions. But on the revenue integrity end, having a denial prevention program in place, and we'll talk through what that really means, but a structured approach to looking at your denials, continuous performance improvement to reduce issues from happening. Having someone responsible for payer contracting, like Jonathan mentioned, that really feeds back the information to the payers to the extent that we can, especially if there's data where you have a certain payer that's way outside of the rest of the payer group when it comes to denial rate. Charge capture, charge reconciliation, having that as a focused effort. It's really on a lot of the departments to do that work, but having someone that oversees it, monitors metrics and trends. And then the last two I'll touch on real briefly. And I'm not sure if I mentioned, but Jonathan and I are more patient access, business office, performance improvement experts. We do have an entire clinical and revenue integrity team that specialize in these different areas. But CDMs and system maintenance, and then clinical documentation improvement, having efforts around there. On just the general staff expertise side, I think it's important to point out where historically your top biller collector may have risen through the ranks and filled one of these roles. I think it does make sense to look at some of these roles and positions more at expertise, either training someone up or having someone in these roles, especially denial prevention, that is strong in data analysis, can monitor, proactively identify trends, look at the tools and reporting that you all have. Someone that's strong in performance improvement, project management. A lot of it, it'd be great if we could automate, just wave a magic wand and resolve every issue, but you need a strong project manager to outline, document initiatives that are being worked on, status, really just keep following up on things. And then obviously the ability to train others and system experience. So that's a few on the structure and people side. On the workflow side, having a sound, defensible financial clearance policy and requirements is a great starting point. So just having it documented, especially for those non-urgent scheduled cases for high dollars, what is required to be seen for service? Do all the staff involved in registration, pre-registration know that, hey, we need to have an authorization in place. We need medical necessity screening performed. We need to verify coverage and benefits. Obviously, training is the second component, but just having it documented and then having escalation procedures. So, and I think it's very client dependent, or I should say organization dependent, but if you do say that an auth is required 3 days prior to service, if that isn't obtained, is there a process to make a decision? Just a structured process. You're not leaving it up to the registrar to make a decision to move forward or reschedule. So that's on the policy side. On the clearance kind of process flow side, having really strong financial clearance reporting and a pre-service process. So I like to think of it as a red light, green light, where, hey, do we have auth, medical necessity, insurance? Has the estimate been communicated? Those things are all visible and then completed, and there's visibility into it a few days prior to service. And I know it's easier said than done depending on your system and technology. And that's the third pillar, is either using your existing systems or investing in some of these real-time verification tools to perform these functions. And then the last two are a little more on the advanced side. So if you're going through and you're like, hey, we're doing a pretty good job here, we have everything that he's mentioned in place. Automation and exception-based workflows, especially around the authorization process. I know there's services and tools that automate the submission of the authorization. There's systems where you can automate or at least create more of an exception-based, where if a service likely does require an authorization, it falls into a separate work list to be proactively prioritized. So you run into less of those scenarios where you don't have something in place prior to service. And then analytics. This is something we offer, a denial analytics tool that I can spend a little bit of time on. but denial reporting that allows you to drill down to the claim level. So actionable reporting where you can see, hey, I know I'm receiving this amount of denials. How many are for outpatient authorizations for infusion? And is it these 3 new cancer drugs or these 2 surgeries that are causing 40% of our revenue loss or 40% of our denials? And drilling to that level of detail and then being able to sample those claims to identify what's going on, to us is really needed to improve performance. Jonathan, do you want to cover some of the basic steps here as far as starting a denial prevention program and strategy?
Yeah, absolutely. So in terms of a denial prevention strategy, really one of the first steps in getting started there is really assessing your opportunity and identifying how much revenue are we losing to denials? How much are we writing off? How much are we adjusting off? And then what do we adjust? What are those adjustments for? What are those different adjustment categories? Something like timely filing or credentialing is probably a little more avoidable than, say, auth or med necessity. So really quantifying how much are we writing off? Where are we writing that off to? Looking at that as a percentage in net revenue, and then really kind of building off of that, really assessing the opportunity for a denial prevention effort. In our experience, a 10 to 30% reduction in net annual denial write-offs is a realistic expectation for an organization that really hasn't stood up any type of formal denial prevention efforts. So really starting by quantifying how much are we losing in net revenue to those denials, how much are we writing off, where are we writing that off to, and then what's the opportunity to actually capture that revenue with the denial prevention effort. And then going off of that, it's really, I want to call it the hidden cost of denials, even though it's not that hidden. It's just that net revenue is much easier to visualize. But that being that rework cost. So the time that your teams take to actually work through those denials, send those appeals out, or if you have that outsourced, how much are you paying a vendor to facilitate those appeals or that rework? So that staffing cost might be a little more, I guess, hidden than the net revenue piece, but still really an important thing to factor in. And there is, of course, an improvement opportunity there as well. So if you're able to reduce those denials, you're going to reduce the volume of work that your teams have to do, and therefore reduce that rework costs. So really one of the first steps is quantifying that financial opportunity, both in terms of net revenue loss and the rework cost, and then really assessing that opportunity to improve. And so now I'll kind of have Ryan talk through the next few steps, kind of once you kind of have that baseline.
Yep. Thanks, Jonathan. Just one thing to add here on the rework cost is you're right. Maybe hidden is not the right word. It's just there's other costs involved. So we use $28 for hourly staff rate. Might be a little high or low, depending on what your business office is at. But there are clinical expertise, kind of physician advisors that are often needed if you think of the cost of physician and like I mentioned, the vendor costs, if you do have to leverage an outside vendor to work these. So that's where it may be a little more hidden. It's not just your staff. And then there's also the team morale component. Hey, I need to battle these day in and day out. And it can become overwhelming. So yeah, on we talked about the first steps as far as calculating opportunity. Another step, and I think it's very relevant because it looked like a variety of people that are on the call here, but establishing a cross-departmental committee structure. And this is meant for hospitals as a sample structure, kind of a mid-sized to larger hospital, but it can be revised. So I'll talk through some of the best practices to keep in mind. Having an executive sponsor. So we highly recommend having someone at the executive level on the financial side, and then a clinical champion to really be effective. So executive component, having a committee prevention lead. So I mentioned some of those skill sets around data analysis and change management, project management, having someone that has the ability to really look at denials in an unbiased fashion. So ideally, it's someone that's not in one of these core departments. Maybe it's someone that works in payer contracting, or it's someone that you hire as a separate department to help, again, identify, help move things forward, help really identify what needs to be prioritized to reduce denials. And then the third component that we have is structured. We recommend subcommittees. So there's 4 here. I would say clinic is some level of involvement on the hospital side, but having between 2 and 4 subcommittees where, for example, patient access looks at their denials that are assigned. So registration, coordination of benefits, authorization, potentially things that they have an involvement in or more than likely could be prevented. Having a project owner at the table, likely a director, and then having project support. If you think support, it'd be who's going to actually look at the claim denials to identify the root cause issues, who's going to do a lot of the training, if there's anything edits that need to be built in the systems, kind of some of your boots on the ground. And then finally, having IT support or involvement, whether that's a revenue cycle systems analyst, just vendor support or IT support in general to create reporting, develop system edits, enhancements. A lot of the improvement opportunities typically involve technology. So that's a little on the actual structure side. As far as the analytics, I know I talked about detailed, more real-time analytics. I'm a visual person, so I'm going to show an example here to really show what I mean. So it is important to have key performance indicators, and we have examples of those. Denial rate is one, but that's just a starting point. What you really want to get towards is, what is my denial total and where are the core of my denials coming from? So a lot of times we'll look at your last 3 or 6 months of denials and see, this is an example where we see authorization as one of the top areas. So we actually drill in and see, hey, it looks like it's on the outpatient side coming from medication and infusion, and it's these 3 drug codes. That's really where you want to get when it comes to performance improvement, and then having a continuous hardwired process to review those and not get too tied up in the follow-up process, but more, how are we going to prevent those from happening again? So I think we're doing pretty well here, Jonathan, on timeline. I think this was mine to talk through as far as just a few examples of recent root cause issues and improvement opportunities. Really builds on that analytics that I mentioned. These would be the type of trends that you want to identify, and some recent opportunities that we've worked with. So let's say you look at your outpatient radiology authorization denials. You find that 80% of those are related to the order not matching the service authorized by the payer. A few of the things that we've implemented recently, some systems have the ability to provide an electronic notification and a work list or a report where if there is any sort of revision to orders for advanced imaging, that goes back to the financial clearance team to review. The other thing that we've seen be effective, a little more manual, but having a tech or someone from radiology department or the ability to look at orders prior to service to say, hey, this is the diagnosis. That physician that may not be an expert ordered a CT without contrast. We actually need a CT of the arm with contrast, and getting that tightened up. So that's one area. I'll touch on one other one, I think, which would be I'll go with the advanced imaging not covered based on diagnosis by payer. Or actually the lab test, I think, may be a good one, where we see pretty often, you look at your high dollar or high volume denials, lab tests may be at the forefront when it comes to just the amount of rework cost involved. So some examples of initiatives, a lot of times we'll see where a test or surgery, the standard order template or set by the physician has a lab test on it that the physician has never really thought through. It's just always been there. It's not really needed. And that's denying for medical necessity. So a lot of times these denial root cause issue identification can lead to more wholesale initiatives where you're looking at order sets as a whole and saying, are there things that can be standardized, or are there things that can be revised? So we talked about technology, denial vendor and automation strategy, and we're not pro outsourcing. We're not against it. What we are for is having a strategic approach to it. So really thinking through some of your core elements and saying, hey, we just don't have the skill sets in place right now, or we don't have the ability to train someone up to handle more of these clinical appeals. So let's leverage a vendor and then determine what we want to do moving forward. So these are some of the areas that we typically see are outsourced or technology is used. Again, Jonathan and I are less clinical, but an outsourced physician advisor, sometimes that's needed. Optimizing your medical necessity screening, your auth tools, your coverage discovery tools. On the post-service side, I mentioned clinical appeal staffing. And then on the rev integrity side, I would say, again, denial prevention analytics, having a bolt-on software solution to be able to provide you visibility into that. And yeah, just a quick, as far as renewed focus on automation and efficiency in RCM. Just a quick study here that was done that highlights this. This is something a lot of organizations are talking about. Automation, vendor technology, it's a top priority. So Jonathan, I think we're doing pretty well time-wise here. We have a slide and then open it up for question and answers. So denials improvement key takeaways. From this presentation, we recommend that you have a strong appeal management process. You address denied claims using the appropriate level of clinical and technical staffing. If you don't have that in place, leveraging a vendor, making sure that your appeal procedures are consistent and standardizing, using templates to the degree possible, using payer contract language, state, national regulations as a defense to overturn appeals. So that's on the appeal side. On the prevention side, strongly recommend having a prevention strategy, having an analytics tool to look at your denials, really focusing on ways to reduce revenue loss and rework cost, and having a cross-departmental approach. A lot of times these root cause issues, you get an authorization denial, and the rework or prevention aspect could span across 4 or 5 different departments. It could be case management, could improve the process, or utilization review for the notification. It could be something on the billing end where the auth just isn't getting on the claim. So important to have all areas of the revenue cycle involved in the initiative. And then I just touched on the vendor and technology strategy, but having a roadmap to really keep up with the payer advances. They continuously invest in technology and automation, so it's important that organizations do the same. So with that being said, I'm going to open it up for a question and answer here, and just this is something we offer as far as a denial management monitoring tool. So I'll mention that. I'd say regardless of whether you're interested in that, we do have, or I would recommend having something that is more real time, that gives you visibility into your claim denials. So if you're just looking at your write-off data today, it's typically too late. You're talking 6 to 12 months after the service has been performed to drive improvement. So having reporting that shows your claim denials, your claim rejections, more of those upfront errors is important. Jonathan, anything else to add here? I did want to open it up. I can take a look at the, see if we got any questions through the chat. I lost that on my screen here. Do you see anything?
No, not in chat yet.
It looks like I got a one-to-one message said good information on subcommittees, question mark.
Yeah, I can because I think we have a few minutes here, so I can cover the subcommittee meeting, kind of how would those look and what do we recommend? Let me see if I can go back to that slide. There we go. So we do typically recommend a monthly cadence to those steering committees. And I talked about the owners, but I think the ideal process is patient access the committee lead may drive the analytics to figure out what to really look at, but then patient access would be assigned, let's say 15 to 30 denials based on where you're seeing the revenue loss. And they'll drill into those. We have a structured approach we recommend, but hey, looking at it to see, was the auth missed? Was it for the incorrect CPT code? So identifying some of those trends and then coming up with some initiatives. So doing that work behind the scenes. And then the monthly meeting is really action oriented, where you're meeting as a patient access group and you're saying, this is where we need to provide education and training. This is where we need to revise our process. So hopefully that's helpful as far as just a little bit of a background, and it does really depend on the size of your organization. So if you're smaller, 3 or 4 monthly meetings may be too much. So you could do more of a front and back end, or even if it's a really small group, just have 1 monthly denial prevention meeting. But I'd say meeting regularly, looking at your analytics regularly, and then sampling claims regularly are the 3 tips or tricks I would recommend.
Please feel free, if you have any questions, you can either send them to the chat or come off of. While we are waiting for those questions to come in, I am gonna go ahead and get those post-polling questions pulled up. If you don't have any questions to ask, feel free to go enjoy some lunch after you fill out these post-polling questions.
Yeah, Caleb, is this something for those interested in the presentation, is it available anywhere, or should we send it out?
That is a great point to make. After the completion of today's webinar, I have an email to send out that will link everybody to the event pages on our website. The first 3 should have their slides and videos already up. This will need to be processed first, but in that email, you'll be able to find all of the web pages correlated to these events, which they'll have the recording and the slides. Yeah, I see people are starting to drop off here. And I'm not seeing any questions come through the chat. So I just wanted to say a big thank you to our wonderful presenters at Forvis who have done a great job on this series, as well as all of you that are participating in this event that are here live. It means a great deal to us. This knowledge is really invaluable. So again, thank you to everybody. We really appreciate it.
Yep, thank you.
All right, have a great day, everyone. And we'll see you for our next event.